The next speaker is Dr. Amir Khorram Manesh, whose topic is training physicians and healthcare workers in disaster preparedness and response, the core competencies. He is a university lecturer in surgery with focus on disaster management, mass casualty management, and trauma. A visiting professor, National Institute of Emergency Medicine, and Mahidol University in Thailand. Current research interests are multi-agency collaboration in emergencies, flexible surge capacity concept, civilian military collaboration and its challenges, development of emergency medicine in middle and low-income countries, hospital safety in disasters, and public health emergencies. He also is active in the introduction of educational initiatives such as simulation training and exercises within the field of disaster and emergency medicine and acts as an instructor actively. Colleagues, Dr. Amir Khorram Manesh.
Mr. Chairman, ladies and gentlemen, dear colleagues, thank you for this opportunity given to me to present my thoughts about training and preparedness in disaster management. As you know, there are many phases in the disaster cycle: mitigation, preparedness, response, and recovery. And the training should be implemented in the first two phases to achieve a successful management in the last two phases. Management of disasters and emergency contains of diverse actions taken in response to the incident, depending on the etiology, and may need to escalate or de-escalate in its various levels. However, in general and within the healthcare, it can be divided into 6 levels as demonstrated in this slide: management and performance on scene, evacuation and transport, management and performance in hospitals, command and control, collaboration, cooperation, coordination, and lastly, communication. It is a chain of action reaction where no chain is stronger than its weakest link. First of all, it is crucial to understand that all through perfect system does not exist due to many factors, and that there are variations among countries with regard to what are the causes of the failure. The most common mistakes, however, can be listed in this slide: leadership not prepared or trained, alert process unclear or not trained, communication not prepared or trained, coordination, cooperation, and collaboration not prepared, understood, or trained, unseen hospital management not realistic, inaccurate training, and too complicated plans which are not trained. Having said that, there is still a need to test and secure the quality of these processes. One way to do that is scientific analysis of results or outcomes from major incidents with comparison and evaluation of methodology. There are published protocols for reports from major incident and disaster that can be used to do that. To manage an incident as well as to test the safety and quality of the management process, we need some crucial information which is described here. We need to have the description of hazards or causes of an incident, description of incident itself, pre-hospital resources, hospital resources, coordination and common process, communication systems used, computer technology and any kind of backup system for that, hospital damage, number and severity of injuries, casualty loads in hospitals, affected population in total, psychological management, and outcome in terms of mortality and disability, and finally, post-accident evaluation of the process. information offers both possibilities and issues that can be used to create a system for simulation. Possibilities are the fact that these results can be given as numbers related to input. Issues are many different variables influence the outcomes, and also how to evaluate the effect of changing, improving one specific method. However, these possibilities and issues allow us to create a system where all variables except the one studied are constant. In that way, we may use inputs and output data to create a scenario for simulation and a simulation model. Having said that, we need to train how to manage an emergency and test and secure the quality of all aforementioned processes. One way to do that is by simulating a scenario. However, there are certain criteria for a simulations model. We need to have input and output data. The input data is what we have to deal with, consisting of available resources such as staff, structure, and systems at different levels of pre-hospital, transport, and hospital. We also need to know the transport time and the geography of the incident. And finally, number and pattern of injuries as trauma score or any other validated score. For the output, which is the result of our performance, we can have the alert in time or accuracy, response in time in different levels, evacuation from the scene in time, priorities for evacuation in accuracy, distribution between hospitals, utilization of resources, and mortality related to trauma score, and finally, complications related to the trauma score. There are different types of simulations with pros and cons and diverse goals that should be used accordingly. Basically, we talk about total enterprise simulations. They can be trained in a strategic management, multiple or single session, working with strategic decisions. It can be business appreciation, a single session, basic decision on basic events and in general terms for all employees. It can be tactical management, multiple or single sessions, tactical decisions, and it can be totality simulation, replicating the entire operations. A simulation can also be functional, focusing on particular areas, concept simulation, emphasizing a specific concept or testing a hypothesis. It can be planning simulation, focusing on preparedness and risk and vulnerability analysis. And it can also be a process simulations, which involves several different kinds of data and finding patterns and discussing the various implications and producing outcomes. Having said that, whatever types of simulations we use, they need to fulfill certain criteria. Development of an accurate simulation model is critical for development of the methodology in major incident response. A simulation model has to fulfill certain criteria to be an instrument for testing methodology and skills. The input data have to be correct and complete. That is, the consumption of time and resources for every measure has to be accurate. And the outcome with regard to mortality and complications has to be accurately predicted. Simulation models fulfilling these criteria are also very suitable for education and training and validation of educational methods. Among several types of simulation exercises, I have found and worked with two types, which I believe cover the needs of any country with any budget and can also be nationalized, as we did in some countries since 2009. Three-level collaboration can be done and conducted as indoor or outdoor exercise. It is scenario-based when sessions for problem solving and group discussions are completed by lesson learned and what can we do better sessions. It aims at developing synchronous collaboration and a strengthened perceived level of learning and utility by focusing on flexibility, improvisation, joint evaluation, and reducing organizational barriers. It can be done as tabletop exercise or it can also include some activity outdoor. Another simulation exercise that I have been working with is module-based and scenario-based simulation, MAXIM, which stands for Mass Casualty Simulation. It has been utilized since 2009 and has been used in other countries like ThaiSim and YUKSIM in Thailand and Ukraine. It targets individual decision making, but also delves deeper into the medical perspective of the management process. It is more complex and may need more instruments and devices which can be purchased or produced in the country that the exercise is going to be conducted. Maxim use patient or patient cards. Patient cards used in Maxim are authentic, taken from real incidents such as Madrid and London bombing, and the method and the course itself has been evaluated and defended as part of a dissertation 2015. Patients have both physiological and anatomical information, as you may see in the picture, physiologically A, B, C, D, E, and also anatomically by showing the picture and with full description of the signs on the back of the card or provided separately. There are tags for treatments given in various level and environment. A tag is given showing the priority of the patient. Thereafter, victims can receive diverse treatment which all consume time. Some measures can be implemented simultaneously while others need to be done before the next one is initiated. The time consumption and the priority of possible treatment have significant impacts on the outcome. That is why doing some specific measurement and management, the patient may not be available for transport and thus missing opportunity to get needed surgery at a hospital. Pre-hospital treatment tags are available for airway, breathing, circulation, or other possible injuries. For in-hospital treatment, other types of treatment tags are used, but according to the same principles with given times and in numbers corresponding to the real access. The system also offers non-disaster patient in order to overwhelm the process and management situation and to test the capability and ability of the participant to manage both disaster and non-disaster patient as it is in a real incident. The system offers a pre-planned organization as shown in this slide with the scene on the right side and then the hospitals and their command centers on the left side. At the top, you can observe the regional or national command center. The system offers a regional or a state coordination center due to the fact that an overall assessment of the situation and having a mutual pictures of what is going on is a significant factor for a successful management of an incident. The center also help avoiding overcrowding, help to distribute resources and competency in a correct way, and also may initiate guidelines and routines that do not exist at the time of incident. It also can be a center for education and research and also finance other activities related to the disaster preparedness. Although very flexible in using the native triage model, the system also offers a very simple triage that everybody should agree on before the scenario play. This slide shows the activities on the scene and also communication way between scene, hospital, and regional command center. On the left side, you can see different spaces necessary for management of the incident on scene, having casualty clearing zone, primary and secondary triage zone, and also ambulance loading zone, together with different spaces for patient, injured, non-injured, and also for command group. On the right side, you may see that the information available on scene will be transferred to the regional command center, which is in connection with hospitals and receive information from hospitals regarding their capacity and competencies. This information, uh, together with the information about what is going on the scene, result in right distribution of patient to the right hospital and medical facilities. The following slides will show the activities during the exercise. In this picture, you can see to the left the primary triage and also designated staff and personnel for each triage patient. And to the right is the activity on the primary triage level. Here, there is a discussion between the ambulance loading officer and medical officer on the left side, while to the right, we will see how patients arrive after the secondary triage to the transporting zone. Furthermore, after secondary triage, people are transported to the ambulance loading zone, and some of them on the right are critical and need helicopter transportation. Please note the time given for arrival and departure of each victim. This slide shows activities in the emergency department from left to right and how these activities are created over time when receiving the patient. As you may see in the last picture, most of the functions needed at the emergency departments are already in place and people are transported inside the hospital to different departments or wards. Here you may see how patients are triaged again at the emergency department and going to different rooms, having some nurses and doctors taking care of them in different zones and areas. A more detailed picture of how patients are taken care of at the emergency department by having a room and a couple of nurses and maybe physicians working with them. Please also note the arrival and departure time. On the right side, you see the possibility of receiving information about the lab or radiological investigations from the instructors. Based on the received information regarding a laboratory result or CT scan or MRI, patient can be transported and taken to the operations theater for surgical intervention. If so, there are, in some cases, information about what can be found during the surgery. Both hospital and regional or national command group are working, providing necessary information and resources to the different wards or hospital or other facilities or to the scene. All information about the incident regarding the time consumed and the resources used are registered and communicated to different levels of management. Time of death, place of death, cause of death, and whether it was preventable or not are registered. All victims have pre-calculated ISS, which will be used at the end of exercise and on final day for comparison, discussion, and evaluation of the performance of all participants in group. I would like to thank you all and also the organizers of this webinar for giving me the opportunity to talk about this topic.